Good evening and welcome everyone to this special presentation and discussion entitled Medical Aid in Dying, The Outlook in Minnesota with Dr. Rebecca Thoman. My name is Anna Froling and I will be moderating this evening's discussion for LWV Rochester. LWV is a volunteer organization organized at the local, state, and national level to encourage citizens to vote and participate in government. I want to thank LWV members for organizing this event. A couple of housekeeping notes before the program begins. Following the presentation, we will have time for questions. Please enter your questions through the Zoom chat box. LWV members will be monitoring questions and passing them on to me to ask during the last part of the program. This program is being recorded and will be made available via a link on our website and Facebook page. You are welcome and encouraged to turn on your camera. To avoid distractions, attendees' microphones will remain muted. And please open the chat box to ask questions, find additional information and links to information. Now on to the evening's program. Legislative campaigns for medical aid in dying are gaining momentum across the nation. 10 states and the District of Columbia currently authorize the practice. Modeled after Oregon's Death with Dignity law, the Minnesota End-of-Life Option Act would authorize medical aid in dying so that terminally ill Minnesotans of sound mind may ask for and receive prescribed medication they could choose to self-administer for a peaceful death. Dr. Rebecca Thoman is a Minnesota physician, longtime LWV Minneapolis member, and is associated with Doctors for Dignity and Compassion and Choice. Dr. Thoman will share the LWV Utah 2016 Death with Dignity study and an addendum that includes updated and additional information from between 2016 and 2020. She will discuss a recent related study conducted by the Minneapolis LWV on this very important issue. So now on to Rebecca. I will turn it over to you, and I think you will want to do some screen sharing too, correct?
Yes, hopefully this will work. Yay.
Yay.
Thanks everyone for joining. Yes, I'm Dr. Rebecca Thoman. I'm a family physician by training, but I don't have a clinical practice. I've been working on public policy and public health for the last 20 years. I work with Compassion and Choices, which is a national nonprofit whose mission is to improve care and expand choice at the end of life. I am also a member of the League of Women Voters of Minneapolis, which is how I got pulled into this, because this is something that the League of Women Voters in Minneapolis took up a couple years back, right before the pandemic hit. We had brought this issue of medical aid in dying up, and that's what I'm going to talk with you a little bit about tonight, what we studied, what we came up with, and what the League of Women Voters in Rochester will be looking at also. So just to get started, the first thing I want to do is make a clear definition about medical aid in dying. It's a very, very specific practice in which a terminally ill adult of sound mind, meaning they have their ability to make their own medical decisions, can ask for and receive prescription medication that they may self-ingest or self-administer for a peaceful death, if and when they choose to do that. So it is modeled after the Oregon Death with Dignity law, and it's a very, very specific. So as we go, I'll talk more about what we know it's not, and some of the misperceptions about it, and what we have learned from the Utah study and other information. So again, this came up because the Minnesota End-of-Life Option Act, which is the legislation that would authorize medical aid in dying, has been introduced actually since 2015 by Senator Chris Eaton in the Senate, who is a nurse, and Representative Mike Freiberg, who is a public health attorney. So we started with the Utah League of Women Voters of Utah did a Death with Dignity report back in 2016, and that was the basis of our program. Since then, it has also been concurred with by these other leagues, New York, Maryland, Delaware, Connecticut, and there are others. So a handful of leagues have already done the same kind of thing where they've studied the report, looked at the report, and then decided to concur with the Utah position, which I will be talking about. So we're not the first state to take this up. And the reason that it is being looked at by the state leagues is that this is a state by state issue. So it's not a federal issue. It's laws that are being adopted state by state. So the US League may never have a position on such a thing just because it's not a federal issue. Anyway, just to clarify that. So also just a little terminology that I'd like to use to clarify, which is people will often say, this is death with dignity. Death with dignity is the name of the Oregon law. It's also the name of the Washington law, and people will equate it with medical aid in dying as a practice, but they're really not equivalent. So medical aid in dying is the term that's used in the legislation and in the statutes that specifically defines the process. End of Life Options Act is the name of the legislative proposal here in Minnesota, and also the name of, for example, the Colorado bill is named the End of Life Option Act, California. And then other states like Vermont and Hawaii have even different names, the Our Care, Our Choice Act. So the names of the legislation may be different, but it's actually the practice of medical aid in dying. And we've moved away from the term death with dignity for a couple of reasons. One is it's sort of suggested that this is the way to die with dignity. And, that is not, we don't have a corner on that. That is, individuals die with dignity in many ways. So to say this is death with dignity, it's just not, we think it's more precise and correct to say end of life options. The other terms that you'll hear that are not correct are euthanasia. And euthanasia is, I like to just say it's typically what we do to our pets, right? At the end of the life, we administer a medication that puts them gently down. That is not medical aid in dying because for two reasons. One is this is not, the person has to do it themselves. It's not somebody giving somebody else a shot. And there are no injections involved. So the person really needs to be able to take the medication, usually by mouth. So it's not euthanasia. And you'll also hear the term assisted suicide. And I'll talk a little bit more about why that term is really not correct and sort of the distinction between traditional suicide and medical aid in dying. So this map is just to show you that the teal colored states are the states that currently have the legislation. There are 10 plus DC, and then the dark blue states have introduced legislation. So it's something that has been picking up momentum in the last decade, especially. And so it was first authorized in Oregon in 94, actually, but went into effect in 97. Washington State 10 years later. Montana had a court ruling that determined that it was not illegal. Vermont was the first state to pass it by legislation in 2013, and then California in 2015. And this is where the momentum really picks up. And the Utah study was put out in 2016. So this additional information that I'm adding here is sort of, we did an update. So we looked at more information for the last 4 years and added that in our report, which included, so Colorado, DC, Hawaii, in 2019, Maine and New Jersey, and then last year, New Mexico became the 10th state. And that's about 22% of the population now lives in a state where this is available. And so just to kind of put it in perspective where this fits in with end of life options overall, when we think about end of life options, pursuing life sustaining treatment is typically the default that people will, try everything generally to extend their life as long as possible. They can also then at some point refuse life-sustaining treatment or discontinue some life-sustaining treatment that has been tried. At some point, they may choose to go to hospice care, which is comfort care only in a setting where you're no longer treating curative treatments to treat the underlying disease, but you're treating the symptoms and providing comfort. Voluntary stopping eating and drinking is another option at the end of life, where often people with cancer, for example, toward the end they'll lose their appetite, they'll lose their interest in food, and it's often they'll just decide I'm done and they'll stop eating and drinking. It's also a method by which some people with later stages of dementia may hasten their death. Continuous deep sedation is typically done for patients who are not able anymore to speak for themselves. They may have a proxy through their healthcare directive, and they're clearly suffering. And so the proxy and the medical team will administer enough medication to sedate the patient, generally put them into a coma, and they will stay in that state generally until they may stop eating and drinking at that point and dehydrate in 7 to 10 days. And then medical aid in dying would be another option. You might think of it as an alternative to the VSED process. Just to go over who qualifies. So there are really 5 distinct criteria that are the same in all the states. One is that this only applies to adults age 18 or older. You must be a state resident. And we can talk more about why that is if there are questions about that. Oops. Oh, there we go. You must have a terminal illness with a prognosis of approximately 6 months. And that is, that's really in line with hospice criteria. So you have to be a 6-month prognosis in order to qualify for hospice. And that's why I think that the 6-month number is what's used. And then the person needs to be mentally sound. And that means they need to be able to make their own healthcare decisions, give informed consent, understand the consequences of their decision, be free from any coercion, acting with volition. And the final piece is that they must be able to self-administer. And like I said, that's typically swallowing. The process is also defined in the statutes, and these are the components that are basically the same in all the states. The patient must submit an oral and a written request. There's generally a document that the patient must fill out and sign. Then the attending physician, and in Minnesota, this is unique to our proposed bill. There's only one state that has given nurse practitioners the same privilege responsibility of participating in medical aid in dying, and that is New Mexico. But in other states are actually looking to give that responsibility or to broaden that provider base because of shortages of access. But in Minnesota, we've already given nurse practitioners the responsibility of acting independently and writing prescriptions independently. So if they qualify for an independent practice, then they would qualify to be a provider here. And then the attending physician has to determine eligibility, be sure that the patient's prognosis, be sure that they have mental capacity. Then they have to do a series of steps providing them alternatives, informed consent. If a patient really has not thought of hospice or is not enrolled, then they should be encouraged and a referral should be made available. Our goal really is to have everyone be in hospice care if it's available to them as a first choice. And then they would refer to a second, either consulting physician or nurse practitioner, to confirm the eligibility and go through the steps. And then if either of the providers is not comfortable with the patient's ability to have mental status, then they can refer to a mental health professional who will come in and make an assessment. And that would be the final decision. And then there are some safeguards in the bill, and I don't go into all the details, but some of the major ones that I think are pretty unique around the nation is that no health professional or institution is required to participate, so they can opt out. And then there is liability protection for health professionals as long as they follow the steps. They are protected from criminal or civil liability. And then it's written in the act itself, and this is true, the language may be slightly different, but in every state, that the actions taken are not for any purpose constitute suicide, assisted suicide, mercy killing, homicide, etc. And this is for a number of reasons. One is and then some exact protections against, for example, life insurance policies, so that your life insurance policy doesn't consider this to be suicide and then not deliver. So, in addition to the legal distinction between medical aid in dying and assisted suicide, the differences are pretty stark clinically. That, in medical aid in dying, this is a person with a terminal disease. It's not a choice to live or die. They are dying. They typically are engaged with their families. They're looking for they want something peaceful to relieve suffering. And it's a planned event, as opposed to suicide, which is often with somebody with either a mental health disorder or a stressor, and the situation or the disease may be reversible with treatment, often is. There's an intent to do self-harm as opposed to self-preservation. The means is often violent. People do this, do suicide in isolation. And so they're very distinct, although there could be overlap, they're sort of distinct looking clinically too. So then our league put together some supplemental material, which is additional information after 2016. And there were three major parts. The first is the year-end data reports. And just about every state now that authorizes medical aid in dying provides an annual report at the end of the year. They collect data on the patients and they put a report together. And that's where we find some patterns of usage. And that's what I'll talk about a little bit, what the data shows. Oregon has the best set of data, the most extensive set of data, I think in part because they were first, and there were lots of questions and concerns 25 years ago. And so they collected more data, and they had a little bit more limitations or more barriers thought of as safeguards at the time. But over the years, we have kind of learned some more information about this. So I'll talk a little bit about more up-to-date year-end reports. Also, there had been some changes with medical associations in the last 5 years, which were not in the report, and then also some Minnesota survey information. So in Oregon, the latest report showed that since 1997 through 2020, there were just under 3,000 patients who received a prescription and just under 2,000 who ingested the medication. So about 2 out of 3 ingested, 1 out of 3 did not. They didn't collect that specific data, so we don't know why. It's possible that they lost capacity, they didn't need it, they died in a different calendar year, so it showed up at a different time. So we really don't know why. But it has really been consistent over the years in Oregon and in other states that about 2 out of 3 patients ultimately ingested the medication. The most common diagnoses, and these are also true in other states, cancer is by far and away number 1. Generally, the second most common is a neurodegenerative disorder like ALS. I think this was the first year in Oregon where cardiovascular and lung disease outpaced ALS, but it was 11%. So what's common for these diagnoses is that they tend to have a more predictable trajectory at the end of life. So some diseases, like there are heart disease where they'll have an episode, somebody will decompensate and then they'll bounce back, and you never always know how close they are to death. But some of these more diseases are the ones where medical aid in dying is used. There's a pretty clear trajectory throughout the hospice and palliative care. As they're losing functioning, they're getting closer and closer to the end of life. Most of the patients, and this is again true in every state, but it's really high in Oregon, 95% are enrolled in hospice and 92% are dying at home. So Oregon actually has a very, very high use of hospice and appropriate use. So they tend to not be people who are going in for 3 or 4 days, but people who may be using hospice for months. Also, the profile of the patient who uses this is they tend to be, and this is also borne out in other states, white, higher educated, insured, So I think that, and I raised this because I think there were concerns 25 years ago that this would somehow be used primarily against the poor or the elderly or disabled or Black people. And it's really the opposite. It's become something that is in some ways a privilege only for people who can afford it, can get through all the barriers and have the money to pay for it. More Oregon data, just to give you a sense, in that year, there were 142 physicians who wrote 370 prescriptions. So again, there was a concern that, there would be one or two doctors would set up some sort of practice where they just helped people. And it's really not, it's become much more integrated into end-of-life care. And there's been no evidence, no abuse, no physician has been disciplined, and there's been no legal action. So there's been a couple studies also that showed that there's really been no evidence of abuse. And then this report contains a lot more detailed information that I encourage people to look at about which medication is used, how long until the time of death, that kind of, which I am not going into on this, and then the other changes are there. Since 2016, there are several medical groups that are no longer opposed, and I think historically they've been opposed. They've used the term assisted suicide and had been opposed, but I think they're moving, more of them are moving toward neutral, which is, for example, the American Academy of Family Physicians. And it's not an endorsement, but it's not opposition. So it's kind of like, similar to an example where they might be on abortion. They're not for abortion and they're not against abortion. They want safety parameters around that. They want to be engaged to be sure that these are done safely. And then within those parameters, individuals will make their own ethical decisions based on their conscience. The American Academy of Hospice and Palliative Medicine is another one that has gone to a more of a neutral stance. The American Academy of Neurology. And again, it's not surprising because of the diagnoses of ALS patients. And then the American Nurses Association also came out with a position which is no longer prohibitive. The American Medical Association did change, it sort of did an update to its Code of Medical Ethics, where it had previously had one section of the Code of Ethics that was opposed to physician-assisted suicide, but the Council on Ethical Affairs came out with a preamble to the section saying that there really are physicians on both sides, and the Code of Medical Ethics also applies to conscience, and doctors can practice medical aided dying and not be in violation of their ethical obligations or in violation of the code. So it's a slight change. I would call it kind of a sea change. It's a different way of looking at this, but that's sort of a nuanced position by the AMA. And then 12 state medical societies, including the Minnesota Medical Association, have also gone to more neutral but engaged positions. And then some survey information. This was a survey done in 2016, a statewide survey, percentage of people who supported or opposed medical aided dying, and it was described, it wasn't just the term used, it was described as, the parameters. And overall, it was majorities in every category, all political categories, greater Minnesota and rural, urban and rural areas, and then also across the religious groups. And actually, the Catholic was the highest group within the Christians that had the highest group of support, which was 71%. And then, of course, the Sacred State Fair poll was done in 2016. This is what the lawmakers love to look at, but it showed 68% of the state fair people who took the poll agreed with this statement as it's written here. So the Utah report did a very nice job of going into the pros and cons, and I'm just listing a few of them, but I think we gave you that Utah report to review, and hopefully you all will have a chance to look at it. But kind of the pros, what are the arguments for this? Generally, it's patient autonomy, to relieve suffering, and the fact that it was safe and no evidence of abuse. The cons are that people, there are some who think it's morally or ethically wrong, or it goes against the Hippocratic Oath and doctors shouldn't be participating. Some will say it's unnecessary, that hospice can relieve suffering without hastening death, and we just need to expand hospice and palliative medicine rather than allowing this. And then some believe that it is a slippery slope where ultimately it will be used against people with disabilities, the poor, the Black, et cetera, like I had said earlier. So those are kind of the pros and cons arguments, and they lay those out nicely in the report. And then our league looked at whether or not this aligns with League of Women voter values before talking about taking a position. And the items that came up were individual autonomy over one's body, privacy, religious freedom, equal access to healthcare, and the fact that it is a state issue would make it appropriate for the state league to look at. So the League of Women Voters of Minneapolis brought up that the League of Women Voters of Utah position, and that we would concur or adopt the similar position, which is support for the legislation, assuming that there are safeguards and appropriate medical personnel involved. And so we took this, the League of Minneapolis took it forward for concurrence, but the 2020 annual meeting was canceled due to COVID. So kind of nothing happened, and then brought it forward last year and had a good conversation. Failed on concurrence pretty narrowly. We had 58% in support, but 60% was needed. There was a lot of good conversation, and actually out of that meeting came this committee now of people from various leagues who are going about doing more education, so that I think a lot of people were unaware, kind of caught by surprise, didn't exactly know what this was. We had done some education at that event, but clearly people wanted more information. And so thank you for bringing this to the Rochester League for discussion. And so it will likely come up again at the council meeting in April of this year. So I'm going to stop sharing my screen, and hopefully there's plenty of time for not just questions, but also discussion.
There, I'm going to unmute myself. Thank you, Rebecca, for presenting that information. I want to encourage people, if you have questions, to submit them in the chat. Right now, there are no questions, but I do have a couple of questions. For more information on medical aid and dying, as well as LWV local and state, please check out the links in your chat box. While there, you can join or renew your membership with LWV Rochester by clicking on a join link on our website. So the presentation portion of the evening has concluded, and we will move on to questions. If you choose to leave now, we thank you for attending. And if you would like to go ahead and ask a question, submit it in the chat box, and I'll just check that, double check that there's no questions. I don't see any questions, but I have a question that I'm going to start off with. You know, I see that there is, you said that 96% were white in higher education. And my question is also with insurance. With the higher education often comes insurance, and also the equity part. I mean, somebody who has insurance feels more agency when they go see a doctor, and also is more likely to have a relationship, a trusted relationship with a doctor when you have the insurance. This isn't about passing or not passing the legislation. It's about addressing the equity for those who may not have as much agency. And this is about autonomy at the end of life. So go ahead if you want to approach that question.
Sure. You know, I think that health disparities are a huge problem. There are end-of-life disparities, and you know, one of the missions of Compassionate Choices is to help reduce some of those end-of-life disparities. And what we know is that African American, Latino are much less likely to have an advanced care directive. They're much less likely to use hospice care. And of course, they're much less likely to use medical aid in dying. And there are a lot of reasons for that. So I think when you're talking about underserved communities, often our first effort is to do more education around hospice, dispel some of the myths. You know, often some of the factors, you know, these are some groups have historically been discriminated against in healthcare. They've had it had a hard time finding healthcare, or they've come up against just frankly racism in healthcare. And so there's some distrust there. And I think it's what we really have to do with those groups in particular is to start increasing health literacy and increasing knowledge about hospice care, because there are lots of folks who don't have an advance directive. They get everything done, maximum treatment till the end of life, and may be suffering, and they may choose that, or they may not know that there is any other option, or may not feel empowered to have any other options. They hear hospice care and they think you're sending me somewhere to die, instead of we're bringing all these resources to make your life great for as long as you have. So, you know, when it comes to those groups, I think that's where we focus. In terms of insurance, though, at this point, the federal government will not pay for any services for medical aid in dying. So Medicare does not cover it. Medicaid does not cover it. The VA does not cover it. And of course, federal employee insurance, health insurance wouldn't cover it. At the state level, some states, and Oregon is the first one, I'm not sure about Washington, several states have used the state portion of Medicaid to cover those costs. And then private insurance is variable. Some private insurance companies will cover it and some will not. But you're right, part of the safeguards that have been put in place make it harder to maneuver through the system. And so you have to have a certain amount of health literacy to be able to do that, a self-agency, and then you also have to be able to afford it. The other thing is, you know, people will say, just go to another state, you know, go move to some other state, which is alone hard when you're at the end of life and suffering, but also you have to have money to be able to get up, pack up and move and leave your family and get a new healthcare group. So that's really not a very realistic option for most people. But you're right, there are real disparities, but I would say they really have a lot to do with larger forces that are true throughout the healthcare industry.
Okay, well, there's some questions coming in. Thank you for that response. Are there any circumstances under current Minnesota law that would allow a similar choice for patients and families?
I'm sorry, would you say that again?
Are there any circumstances under current Minnesota law? I think what they might be asking is it possible to do it now with the laws that are existing? But I'll finish reading the question as it was printed. Are there any circumstances under current Minnesota law that would allow a similar choice for patients and families?
You know, I think that and now we're just talking about patients who have full volition, they have, you know, decision-making capacity. At this point, the option they would have would be the voluntary stopping eating and drinking. So a person could certainly say, I'm done. With proper medical support and care, they can get through that process. It's about 7 to 10 days. With the proper medical support, it's not too bad for the patient once they get through the thirst part, but they will have organ failure. They will get medications so that they are comfortable through that process. Sometimes it's hard on families to go through, but that is an option that, you know, people could choose in Minnesota now. Often, and if patients cannot speak for themselves, again, the deep continuous sedation is always an alternative that's used in hospice and palliative medicine to control uncontrolled pain. And, you know, most people are completely comfortable and, you know, they get hospice care that gives them the care that they need. So this is really, medical aid in dying is pretty rarely used. It does have the added benefit, though, of providing comfort just knowing it's there. I think people feel like they're less afraid. They know they have this out or this option, and it allows them to relax a little bit more and reduces their stress and allows them to enjoy the quality of their life that they have. So whether or not they would use it, just kind of knowing it's there as an option can be a benefit.
Okay.
I hope that answered the question.
And if it didn't, do a follow-up question in the chat and I'll ask that. So what means would you recommend for interested voters to advocate for this bill?
Well, just in terms of the politics of this, I would say that it's always a matter of demand. If people want this, then they need to talk to their state lawmakers. So your House of Representatives and your state senators. So I know Tina Liebling represents a portion of Rochester. She actually has been an author of this bill in the past, so she is supportive of it. Your senator, you have two there. So I would say you need to reach out to your representatives and your senators and talk to them about it. Tell them why you think this is important. Answer their questions. You can always affiliate with an organization. If you're in the League of Women Voters and the group decides to support this, then of course there's a lobbying team that you can work through with the League of Women Voters. If not, Compassionate Choices is an option for anybody. But I would say, be in touch with your lawmakers because they need to hear from people about this. It's, as you can imagine, there are so many pressing needs. And so they're hearing a lot about all these pressing needs, and this often will be under the radar. Oh, I see the question about dementia. I'm glad you brought that up because I should have said people with dementia do not qualify for medical aid in dying because by the time they're really terminally ill, they've lost the ability to make their own decisions. So voluntary stopping eating and drinking is an option for people with dementia. And actually, you can get specific information on how to write a dementia provision to add to your healthcare directive. But you really have to plan that ahead. If that's something you're interested in, if you're feeling, boy, if I get dementia, I want to have this option. You need to really think in advance. Talking about it with your family is critical. Making a video about what you want, documenting it, giving instructions, and there are resources online that can help with that. But that's, at this point in Minnesota, and really anywhere, VSED is probably the best opportunity that you have to reduce the length of time of suffering with advanced dementia.
Okay, thank you. So another question that we have is, you talked about organizations that were neutral. Could you go over the organizations or groups in Minnesota who support this legislation?
Oh, support. In Minnesota, there are just a few that actually come out in support. So I think the Unitarian churches, trying to think who else besides Compassionate Choices. Oh, I think the Rainbow Health, some of the groups, there are some groups out there. Primarily the health groups are not taking a position one way or the other. Most of them are saying, we're not for or against this. And I think that's probably appropriate. So most health groups are not, but the groups that are in favor tend to be sort of the activist kinds in the churches, some of the churches.
What is the interaction between advanced care directives and VSED and medical aid in dying? Can it be part of an advanced care directive?
No, and I'm glad you asked that to really clarify it, because remember, an advanced care directive comes into effect when you can no longer speak for yourself. So you name an agent, a person who's going to speak for you if you can't speak for yourself. Medical aid in dying requires you to be able to speak for yourself. So there's no substitute judgment on this. You can't put this into a healthcare directive and have somebody help you do it later. It doesn't work that way by definition. VSED is something that you need to write into your advanced directive to give people support and to know that you want to do this, but especially in dementia where you may lose the ability to communicate, you may have enough changes of dementia that people are going to rely on what you've written in your healthcare directive to determine what kind of care you receive. So medical aid in dying, completely different from VSED advanced directive.
Okay. Thank you for the, one of the participants says, thanks for the presentation. And with palliative medicine and hospice, most patients die with serenity and pain well controlled. Please comment in context to the program you have addressed.
Sure, and I think that's absolutely right. Although data shows that somewhere between 25 and 50% of people die in pain, that doesn't necessarily mean those people are in hospice. So what percentage of people in hospice die in pain, I think is a lot lower than that. And he's absolutely right. Hospice does in fact do very well for most people. And if you look at the profile of people who use medical aid in dying, a lot of this has to do with value system. They're people who are very much in control. Often cancer patients will be saying, look, I fought this cancer for 5 years. I'm not going to let it take me. I'm going out on my own terms. So a lot of this has to do with kind of the value system or the personality of the patient. They like control. They don't want to go through that suffering. Often they've seen another loved one go through the suffering. They don't want to put their family through that. So a lot of it will have to do with those kinds of considerations, or they've just felt like, my quality of life is really done for. Why should I go out these last 6 weeks suffering when I'm miserable? So let's just end it end it now. So I think that there are a lot of factors that go into that determination. And again, it's really people have a pretty clear trajectory that their life is coming to an end in the next, months, weeks to months. So it's a piece, I would say it's a very small piece. But just knowing it's there provides a lot of help for people. But you're right, most people don't need it and don't request it.
Okay. The League of Women Voters, Red Wing, have joined. Many of the members have joined, and
great.
they wanted to get educated on this issue and legislation. The question is, what is the interaction between advanced? Oh, I already asked that. Oh, yeah, I already asked that. Sorry about that. I have a question. In like the states that already have it, has it affected the attempted or completed suicides among patients that are at the end of life? Are there data on that?
There is not good data on that. So I don't know that there's even data on, in states where medical aid in dying is not authorized, there are patients enrolled in hospice who will end their lives. They'll use a gun or they'll try their own medication overdose. I don't think we have any data on that. So I don't know that we've collected data to know that. So it would be a good thing to learn more about.
And I'm looking to see if there's any, and has COVID or the opioid situation, has that affected this the medical aid in dying process of getting this approved in states or anything?
Well, I think the COVID pandemic has had a twofold effect. One is people have been seeing up close and personal how bad suffering can be at the end of life. And when they see people gasping for air and dying in desperation, I think it's made people realize how painful that can be. And second, to know that they better get prepared. So it's really a surge of people doing advanced care planning, which is good. So I think those are kind of the two things that have come from this COVID response as it relates to this topic. And then,
okay.
Sorry, what was the other question?
So I think I asked about opioids and
opioid.
Yeah.
It's funny because I think that as there's been more attention to the opioid epidemic, there has been, and this is not, I don't have data on this, but people are concerned about hospices not giving enough pain medication for fear of creating addiction. I don't know how prevalent that is or if that's really a thing. But I know that there is concern with giving enough pain medication. So it's a real tight balance. I think we really need to fight for adequate pain medication for hospice patients. They should not have to suffer at all. And that has nothing to do with the opioid epidemic, except in the proper disposal of unused medication. And hospices have programs for that. So I don't know if there's even any data on whether any hospice medications, make it out into the world and contribute to the opioid epidemic. I don't know. There may be out there, but that's not anything I have information about.
A question that was asked earlier, and I should get this in, is do you know where people can find the link to the Utah study? And if they go to the League of Women Voters Minnesota, can they find the information there through that?
Yeah, I think I sent that to you all as an attachment, so that I sent, and maybe if I didn't, I'll send it to you after this. I can send you the Utah study and the addendum with the updated information, and then the actual Utah position. So I'm happy to send that to you. Oh, somebody put it in the chat. They found it.
Let me see. Yeah.
Awesome. But so I guess you can download it there, but I can send you the addendum because that's not available there.
And if anybody wants to put their name in the chat with their email, we can send that to them also. There's another question. Let me see. I have to find it. Sorry. What are the numbers of people dying in hospice with pain well controlled compared to the 2,000 using medical aid and dying? I think what percentage of people using medical aid and dying are in hospice? And also, can they do, with a hospice that's at home, they can do this. Can they do this at a hospice or an inpatient setting hospice that some people go to?
I'll take the last part first, which is it's variable and it depends on the hospice policy. So in Oregon, a third of the hospices there will support people all the way through the process up to ingestion. At about a third of them, they won't do it at all. Often religiously affiliated hospices will not participate. And then some will do some help, but they won't let you ingest. So it's variable. They're going to have their own policies. But in Oregon last year, was 95% of people who chose medical aid and dying were already enrolled in hospice. Pain is not the leading cause, so I don't know what the numbers are, but I'll bet we could find it in the Oregon study. I think it was 25%, 20 to 25% say they have pain as one of the reasons for choosing this. And I don't know how that compares to pain control in hospice patients in general. So that's a good question. But pain isn't necessarily the number one motivator.
And I'm just looking to see if there's any other questions. We will post the Utah study and the links to the other information on our website at www.lwvrochester.org. Should a mental health evaluation, another question, should a mental health evaluation be required before someone is eligible for a prescription to end their life? I think that, go ahead and answer that.
Well, that's a should question. I'll tell you that in every other state, there's only one state that requires that, and that's Hawaii, and the other states do not. The way it's written is that if there's any concern about the mental status, then they call in a mental health assessment. I think when you're talking about a patient who is in a hospice setting, they're surrounded by a interdisciplinary team of experts, seeing them regularly, nurses, social workers, chaplains. And so that patient is very much that team has a good sense of that person's mental capacity. And the physicians and nurses evaluate mental capacity all the time when they want to get informed consent. So I don't think knowing that a person can give informed consent, it's something that doctors do every day and hospice workers of all kinds do frequently. So I would say, in my opinion, only if it's necessary. I don't think it's been seen more as a barrier than as a benefit to require one for everybody.
Okay, and I would just listen on the New York Times Daily. It's a podcast, and it was followed a woman in Belgium, and to get all of the different kind of things that had to sign off for their euthanasia. It was she talked about the difficulty to do that at the end of life. So that was interesting too. That with hospice, oftentimes they're already connected with these care providers, which is nice. I'm going to look and see if there's.
I
Go
just
ahead.
want to add that I think it's really important to know that we're not comparing apples to apples when you look at these laws in other countries, because they have different criteria. They have they don't require necessarily terminal illness, but they define unbearable suffering. They don't require people to self-ingest. In Canada, for example, most medical aid in dying is provided by infusion. So it's really not a one-to-one comparison. Every country has slightly different versions. And they didn't start tight and loosen up. They sort of started, they sort of came fully formed in a very different sort of cultural concept of end of life.
Okay. And there's another question. Until the law is passed in Minnesota, do you endorse use of the POLST form or other approaches to advanced care directive to help families with such decisions?
Oh my gosh. Yeah, that's a big part of, that's a big part of what my organization does, is educate people about that, about the options, dementia addendums, that kind of thing. So absolutely. And trying to break into communities where there's less knowledge and less trust around healthcare planning, end of life planning.
I'm checking to see.
I have another, I should try to find the link to this and put it in the chat, but on this Friday, the University of Minnesota Center for Bioethics is holding a symposium on this topic, medical aid in dying. They're doing a two-part series. This Friday, they're doing the pro side, and then a couple weeks later, they're doing the con side. And I can try to find that link real quick.
Okay.
But if anybody's interested, I think it's over the lunch hour.
Okay. There's another question. If patients with early dementia or Alzheimer's, and we can put that, if you find that and send it, we'll put it on our website also. If patients with early dementia or Alzheimer's who are still able to make their own healthcare decision and would like the option to end their lives, should aid in dying laws incorporate that need? So that's early dementia and Alzheimer's.
Well, that's a should question. And I think that's a matter of opinion right now. Oh, somebody found it. You guys are so fast. Right now you have to be 6 months. You have to have a 6-month prognosis. So early dementia, it would not be an option. VSAD would be an option, but medical aid in dying would not be an option.
Okay. And I think we are at about the end of our questions here. We'll get that information on our website so people can look at the Utah study, which was interesting to read, and also the addendum by the League of Women Voters Minneapolis League. And so we want to thank you, Dr. Thoman.
Thank you,
Rebecca, for coming this evening and presenting information. And I think this will be coming up at the spring. Will this be coming up in our annual meeting at the end of the year in April?
It's actually the annual council, which is at the end of April. So
okay.
a proposal for concurrence with the Utah position is what will come forward.
And concurrence means that we accept their position.
We agree with that. We agree and sort of adopt that position. Yeah.
Okay. Okay. And so I want to thank you and thank you for the service to the community and for educating and working on this. Advocacy is hard work, and you have to be tireless to continue to keep doing it day after day.
Well, thank you all for your interest. I really appreciate the opportunity to tell everybody more about this.
Yep. And do you have any final words before we leave?
Just thank you for opening your minds and listening. And thanks for being part of the League of Women Voters. Yeah, go League.
Yeah. Thank you.
Thanks.
And if you want to advocate on this, you can join the League of Women Voters Rochester, which also makes you a member of the Minneapolis or the Minnesota and also the US. We have some upcoming events coming up, Impact on Issues. It's public policy and positions of the League of Women Voters National. And you can join us February 5th at 10 a.m. It's a virtual program. It's for members only, but if you wanted to attend, just throw us an email and I'm sure we would welcome you. And also how the court systems protect youth is February 9th. It's also a virtual program, and that's going to be from 7 to 8:30, very similar to this. And then January Jumpstart, the LWV Minnesota has January Jumpstart, which is happening in the afternoons, both tomorrow and Thursday. And you can check the LWV Minnesota website to sign up for that. And it's going today we had a lunch and learn about democracy, one of our priorities at the state. And then we also will be having climate change and racial justice. And those will be the lunch and learn from 12 to 1. Thank you everyone for coming this evening. And again, thank you for Rebecca, Dr. Thoman for presenting the information to our local audience. Thanks and have a good night. Bye-bye.